those who are joining us online, good evening to you as well. Welcome to University of Wollongong Southern Highland campus. It's a pleasure to have you here this evening for our public engagement session called Meet the Researchers, and our researchers are here for you. It's part of UOW's commitment to reach more into our communities in an authentic way, and in this particular instance, to bring our research to our communities. At the outset, I'd like to acknowledge the traditional custodians of knowledge, the lands on which we meet today, and for all of the people who are joining us, for the traditional custodians of knowledge of the lands of those people as well. And extend my respect to elders past and present, and to anyone of Aboriginal and Torres Strait Islander descent who join us this evening. So the Meet the Researchers is, as I've said, about bringing more of what the University of Wollongong does to the communities and the public in which we find ourselves, to those precincts. And it's done around all of our regional and metropolitan campuses in turn. This is the first one that we are hosting here at the Southern Highlands, and it's really wonderful to have everyone here this evening. It is about connecting what we do to the public sphere. So our presenters this evening, our first one is Michelle Townsend, who is Senior Lecturer and Senior Research Fellow in the School of Health and Society and School of Psychology in the University of Wollongong's Faculty of Arts, Social Sciences and Humanities. Michelle brings together 2 decades of expertise in responding to adverse childhood experiences. Her research spans the disciplines of psychology and public health, with the goal of understanding, preventing, and responding to child maltreatment, mental health disorders, self-harm, and suicide. Join me in welcoming Michelle this evening to discuss her work under the title Self-Harm and Suicidal Behaviours in Children, Progressing Our Understanding. Michelle.
Thank you, everybody that are here today, as well as those that are joining us online. There's 3 things I'd like to leave you with today. The first is, I guess, a bit more understanding and awareness about this issue, and the fact that it is quite overlooked in our progress around suicide prevention. Secondly, that we all have a role to play in supporting children and their families around this. And thirdly, I guess get your support around that we do need to be doing more research and more consultation to really increase our understanding, which is quite limited at this point in time. So the focus of my research over the last 5 years is really on improving communities' awareness of this issue, looking at ways that we can intervene across settings, so homes, health services, schools, but also translating our research to be able to support our prevention and intervention efforts. So I would like to also acknowledge the traditional custodians of the lands on which we meet and pay my respects to Aboriginal elders past, present and emerging, and extend my respects to any Aboriginal and Torres Strait Islander people that are here today. I'd also like to acknowledge those with lived and living experience of self-harm and suicidal behaviours, and those that have been bereaved by suicide, and those that are caring both in professional capacity but also in personal capacities for children and their families, and really acknowledge the challenges and the difficulties that you can face in that. So I've just got the statistics there, but I am going to talk about some prevalence figures in that today, and I don't at any one point want to dismiss the fact that I'm talking about individual children and their families, and really that's at the heart of what I do. Okay, so this presentation obviously will be around self-harm and suicidal behaviours, and a little bit I'll touch on childhood maltreatment, so just be aware and mindful of your own well-being. There are some support services here. If you have to step out or leave at any point in time, please do so to make sure that your well-being is at the foremost. So I'm going to start by giving a bit of background about the research that I've been doing. And we've really been thinking about exactly what is self-harm and suicidal behaviours in children, and is it different from other age groups? And how do these behaviours be quite distinct from each other, but what are the overlaps as well? So just to give you some background for those that are less familiar, we see self
Sorry.
Okay, so when we're thinking about these behaviours with children, we really need to think about say 8 years old compared to a child that's aged 12-year-old. We also children that have had come from different cultures, they've had different exposures to death and dying, and can have different children may have had in their lives around self-harm and suicidal behaviours, and to the extent that they may understand the consequences of their actions. Now, I like to use the iceberg to sort of understand what's happening in our communities. So at the tip, we have the very tragic situation of a child or a young person or anyone's life that is lost by suicide. And then below that, a larger group we have of children that are presenting to health services, so ambulance, emergency services, ED, as well as their general practice doctors for support with their families. But below that, we have a group of children that are not getting help or the support that they need. And at times, their families are not even aware that they're experiencing these behaviours or having these feelings. And that's, I guess, one of the groups that we really have to keep in mind because they're not presenting and we're not aware of them. So the research I've been doing is looking at a whole of systems approach. So how is it that we work together with parents and carers, with school educators, with school psychologists, and child really understand what's happening. And alongside that, framing it is looking at some of the understand more about what's happening. So the first piece of research that we've done is looking at teachers. So these were high school teachers, and we were looking at particularly around self-harm and complex mental health presentations in that age group. And what they told us is that they saw that the average age of self-harm behaviours occurring was about 12 and a half years, which for some children could still be in year 6. Many are in year 7. They estimate that about 1 in 5 high school age children were engaging in self-harm. And they talked about the struggles that they had with this increasing number over time that they were seeing and aware of, but that they didn't feel like they necessarily, or schools themselves and parents, had the resources to be able to support these children effectively. So knowing that teachers were saying the average age of onset was about 12.6 years, we then had a series of interviews, in-depth interviews with parents and carers was happening, and they really talked about the challenges that they didn't know how to respond, and when they first were made aware that they were experiencing a lot of distress and that sometimes they responded in ways that weren't that helpful. They also talked about how retrospectively that their children were engaging in these behaviours from a much earlier age than adolescence, but that they hadn't really seen that at the time. And they talked about the significant impacts it was having on their families and on their own lives in terms of reduced capacity around being able to engage in work and other relationships, as well as impacts on their own mental health. Following on from that, we went and had a look at some of the data that was publicly available. So the New South Wales Department of Education develops reports every time there is what's considered a major incident within school. And at that point in time, self-harm and suicidal behaviours in students fell into that category. And what we found from this research is very much when these children were made aware to the schools, that often it resulted in police and ambulances being called to respond to those behaviours. And I guess the takeaway for us was very much, this is a real opportunity that we've missed to intervene earlier before we get to the point where we're having to intervene, with emergency responses. Which I have to say, sometimes that is completely appropriate because we need to have an ambulance there, but at other times that can then change a child or a young person's help-seeking trajectory because of the distress and the shame that they can feel about this. We then went and talked with primary school psychologists here to sort of understand from their perspective what they were seeing in primary schools. And they saw that the average age of students presenting for self-harm and suicidal behaviours is around 10 years of age, and saw it very much as a coping mechanism for the stress and anxiety and bullying particularly that they were experiencing. They felt very limited in the support that they could provide to students and families because often they were only in schools once a week or once a fortnight, and again reiterated the fact that we have very limited resources available for families and for educators on these topics. So final piece of research that we've done recently is understanding from child and adolescent mental health clinicians that work in public health services to see what sort of behaviours are being presented in children aged 12 years and under. And they were very clear that it does, that the presentations can really differ in terms of adolescent populations. Both in the behaviours that are being utilised, but also in the ways that they then respond. And they had a focus very much with the younger age group of ensuring that parents, wherever possible, or carers, were really involved in supporting them to be able to respond, because they're the ones primarily caring for children at home. They did, again, reiterate the fact that there are limited services and supports that are available to families in this age group across the different areas. So I guess what I would like to leave, the parents and carers and the clinicians and educators that are here in the audience today is that we really are trying to listen to the feedback that you're giving us and I guess advocate and develop resources and things that are going to be helpful in terms of this clear need that we have. I just want to turn now a little bit to some of the data that we've done in the Illawarra Shoalhaven Local Health District, which runs from just below Helensburgh down to Milton Ulladulla. Now this research was done with data just before the pandemic, but from 2011 through to 2019, and we were looking at the total number of presentations to emergency departments of 5 to 12-year-olds for self-harm, intentional poisoning, which can be sometimes a self-harm behaviour, but sometimes can be intentional in terms of a plan to take their life, as well as suicidal behaviours. And what you can see is that there has been a steady increase in the period up to 2019, which is in line with what our educators and others have been telling us. But when we look a bit more deeply at the data, you can actually see that intentional poisoning is slightly decreasing. Self-harm has a slight increase, but actually the presentations that really are coming to emergency department is around suicidal behaviours. So that's something that we really need to be mindful of, that there is an increase in terms of presentations, and whether that's through, we're getting our message out there about that this is an issue and we need children to be supported, or whether it is that we actually have increasing numbers that are really driving this. And as I said, we've got the presentations, but then there's that group, under the water in the iceberg that we are not seeing. So the estimates in Australia is about between 2.5% to about 6.5% of children engage in self-harm behaviours. And internationally, the prevalence around suicidal behaviours is about 7.5% for children aged 5 to 12 are engaged in making plans. Our thoughts about suicide, about 2% in making plans, and then just over 1% have actually made an attempt. And here in Australia, on average, tragically, one child aged 14 years and under dies every 11 days by suicide. So this is a really important issue that has, at times, as I said, been overlooked, and it's one that we still don't understand a lot about. What we do know is that there are some risk factors for both self-harm and suicidal behaviours that are quite common and that perhaps overlap. So mental health difficulties certainly has been shown internationally to be prevalent. Interpersonal difficulties, so you know, whether it's with family or with friends, can be really challenging. Past self-harm or suicide behaviours is also a risk factor for suicide. And throughout everything, I just want to say that while these are known risk factors, it doesn't explain every child that has these behaviours and experiences. This is like a sort of a global statement. We know that some children die by suicide without having any of these risk factors. And that's what I guess we're also trying to understand as well. But child maltreatment, and particularly children that are experience socioeconomic disadvantage, appear to be at higher risk of engaging in these behaviours. So with all the research I've been doing and listening to stakeholders and talking with community, I've developed, I guess it's a bit of a model to try to think about what is happening for children. And particularly what I would like to say is, for those of us in the room, the nature of childhood is changing. Our children are growing up digital natives. They're growing up with exposure to the internet from a very early age. They've all grown through the COVID-19 pandemic. Now, we all had experiences with that, but not necessarily all of us were going through key developmental stages in our lives. They have worries for the future. They're worried about the climate. They're worried about wars. There's a lot that's happening for them. And that comes up when we do global, Australia-wide studies. That it keeps coming up, is that they have a lot of concerns. And there is experiences where there is increasing disadvantage and inequity happening for our children and their families. So some of the other factors that really appear to be driving suicidal behaviours in this age group is where there's complex family breakdown and disruption, when children are experiencing mental health difficulties, and when there are factors around their developing identity that may be not accepted by their peers or their families, or that they're struggling themselves to be able to understand, whether it's understanding about their sexuality, gender, their body, culture, all of those factors. And the other one that really, I think the strongest evidence is internationally, is that childhood maltreatment is particularly linked to suicidal behaviours. And that has a long reach, like it goes well beyond just childhood, but it is something that we have to keep front and centre, that it's important now. But alongside that, we have those factors, but generally there is some precipitating factors. So whether that is, a significant discipline issue, or a relationship blow up in some way, often that can then lead to these suicidal behaviours. I talked before about we don't necessarily understand, like some children have sort of none of these sort of risk factors, and impulsivity I've listed there as something that I think we need to be really mindful of and understand a bit more in terms of the role that plays. So there's a lot we don't know. There's issues around data because it's a sensitive topic, so we don't publish a lot of data to, sort of around children 12 years and under. As I spoke before, we don't understand necessarily about the intentionality of children. We don't know if there's unique risk factors for this group that differ from adolescent populations, or whether, there is some risk factors that are particularly more prevalent for self-harm as opposed to suicidal behaviours. We have some ideas about what may work in terms of risk assessment and treatment, but I still think we've got quite a bit, and there's definitely no gold standard as such in terms of those treatment approaches that's agreed upon that work really effectively. As researchers, we don't share common definitions necessarily, and we all ask different questions when we're trying to understand about this issue. And asking children about this raises a lot of ethical concerns. So that's a big one for us, because we think if we don't talk to children themselves, given we know that at least half of children don't share information with somebody else about the feelings that they've had, we're going to really miss our understanding. So collaboratively, we've been working with people with lived experience that are now older, and with parents who have children in this age group, as well as clinicians and academics, to develop a really sensitive and ethical assessment tool so that we can ask children about these behaviours and also then respond in effective ways. It's aimed to be used by clinicians, both within health and education settings, and we're at the point now where we're looking to partner with people around piloting this assessment and developing it further. And the next steps is really the translation. So as I said, we would really want to understand more about the risk factors, particularly for children, and get that information out there so people know. And that's partly about, talking to people and gathering that information, but also about synthesizing what the literature is internationally. We would like to develop some guidelines that clinicians can use, because at this point in time that doesn't exist for this age group at all. And really, and most importantly, I think, is that more information and resources for parents, for educators and carers, because that is a real gap that has been identified. And that's the things that we're going to really help us in terms of that prevention, but also then the identification and intervention. So this program of research that I'm doing with collaborators is really about trying to give us new knowledge to be able to respond to children who are currently experiencing these behaviours or maybe at risk of it, and really supporting their families as well. I'd just like to acknowledge all of the collaborators that have worked on this research program, also the research participants that have generously shared their time, the supporters that I have at the University of Wollongong, partners and funders. And I just, for anybody that would like to, you can just scan it with your phone or pop in the, and just if you want to leave any thoughts or messages, or even if you want for me to get back in contact with you, you're very welcome to.
Well, thank you very much, Michelle. That was really insightful. Please don't go. Yeah. So it's really amazing work that you're doing, and so timely and topical. And the guidelines, that evidence-based guidelines that you will be generating, will really fill a need. I'm going to open the talk up for discussion, and that will include in the room and then also online, and I hope Martin can help us with online. But I'll just lead off. So while we are waiting for those guidelines that you will create, what is the sort of distilled essence of advice that you would give to people on identifying and correctly responding to circumstances when they believe that the child in their care may have these thoughts or activities on self-harm or suicide?
Yeah. So my advice would always be to actually directly ask, and you would have to think about the age of the child, and that's what we've tried to do within that assessment about the framing of the questions. But the research internationally very strong in that asking around directly children, young people and adults about self-harm and suicidal behaviours is far more empowering than not asking at all. It does not lead to those behaviours. What it does is it allows people to open up about that they have those feelings, because you've given them that space to do so. So I think if you are concerned about anyone, please ask directly.
And as a follow-up, people may be fearful that for children who haven't had those thoughts, it might precipitate those kinds of thoughts. Is that valid, and what would your response be? And then I'll open up for questions.
Yeah. I mean, with younger children, potentially you would, if you think that they haven't been exposed to words like suicide or anything like that, you may talk about hurting yourself, and and you may give some examples about how they might hurt themselves to try and draw out whether they've had thoughts or punish themselves. Like you may have to be a little bit creative depending on the age of the child. But I think to understand if you have a child that is presenting with distress, definitely it is something, you're not distressed about a specific incident then and there, but if you can see there's a pattern of distress that's happening over time, then definitely I think we need to be asking about this, because we know that children are experiencing these feelings and these thoughts, and that they're not necessarily sharing them with adults, trusted adults in their life.
Yeah, that's really important. Don't shy away from it. That's really important. Any questions online?
Yep.
And I'll repeat them just as...
Yeah, sure. So there's one from Sally who asks how best to support callers to Lifeline who are struggling with their mental health.
So the question is how best to support callers to Lifeline where the callers themselves are struggling with mental health. Right.
Is it Sally? Yes. Sally, that's a really tricky question. You could write an entire thesis on that one. Lifeline does such an amazing job in terms of their support for struggling Australians. Like, it's just such a service that we have. I think there's no easy answer for that one, but I know that the staff are very well trained in terms of that, validating where people's experiences are, and doing that level of questioning around, are you thinking about these sort of, self-harm or suicide, and then being able to put the support that's necessarily in place for that. And the same with Kids Helpline. So Kids Helpline is probably experiencing the same thing as Lifeline, that there has been a marked increase in the number of presentations of both children ringing, but also parents ringing about their child that is experiencing self-harm and suicidal behaviours. But yeah, so I don't have an easy answer, Sally, about your question for Lifeline, but I think it really is about, firstly, always making sure that we recognise the distress that people are experiencing, and be asking those questions about, are you thinking about taking your, you wouldn't say taking your life, but are you thinking about, when people are feeling really distressed, sometimes they think about suicide. Is that something that you have thought about?
There's two more questions here, if we've got time. Do you want some more questions?
Please.
All right, so the next one is, would self-harm behaviours include drug taking?
So would self-harm behaviours include drug taking?
Yeah. So that is a topic of a bit of debate within the academic field. Within the definitions that we use, no. In the child population, we're not saying that unless it was an intentional poisoning. Yeah. But I can see why people, could consider that in terms of the harm that it can cause. Yeah.
Sure. There are more questions, yes? Ross asks, what are the proportions and statistics for girls versus boys?
Yeah.
Can you help us out with that, and other genders?
Right, proportion of girls and boys and other genders.
Yeah. So I can't, sorry, it was Ross. Yeah, sorry, Ross. I can't say much about comment on other genders because, as I said, because we're talking small numbers, it doesn't tend to get broken down to that level of detail. Like, we really struggle to understand. So I can say that definitely in terms of self-harm, it is far more likely both in children and adolescent populations to be girls or young women that are presenting for self-harm. However, our study in the Illawarra Shoalhaven local health district, as well as lots of international studies, actually showed in the age group 12 and under that there's fairly equal representation in terms of both males and females experiencing suicidal behaviours.
In the room? All right.
Just you made a powerful point about once you engage the child in the narrative, it would appear, the way I interpreted it, the child is then empowered to talk about it and almost an acceptance that it's no longer a secret within, but it's spread and it will help. So that said, is that message being passed into the educational authorities such that they can engage the subject right now as a curriculum topic per se or something similar?
Yeah, that's a good point. My work has been thinking more with this sort of intervention with adolescent populations, and I have to say that educators can feel really challenged by introducing these sort of topics within the curriculum for lots of reasons, and sometimes it's that they don't necessarily have the support, training and that they need to be able to have these conversations. However, I think that starting with particularly school psychologists and student wellbeing staff and getting them to have, I guess, the language and the approaches is a really good starting point. And then hopefully from there, we could put it more broadly across, all educators. But for me, suicide prevention is for me, it's number one public health issue. It's something that we have to get across everywhere because it touches all aspects of our life and workplaces and schools and our community. And we really do need to be talking about it. And we do need to be talking about the fact that children under 12 and under are experiencing these thoughts and behaviours, and to be able to do more about it.
All right, thank you very much, Michelle. So please join me in thanking Michelle. Our next presenter is Associate Professor Alfredo Paloyo, who is Associate Professor of Economics in the School of Business in the Faculty of Business and Law at the University of Wollongong. His research interest is in the empirical analysis of issues related to human capital, particularly in the fields of labour, health, and education economics. He has published widely in the international literature, and you'll hear some of that research shortly. Today, he'll discuss his findings relating to the influence of prolonged periods of restricted movement and what that means for mental distress, particularly in vulnerable groups, such as young adults, women with young children, and individuals living alone. His presentation is entitled Lockdown's Damage to Mental Health, and welcome, Alfredo.
Yeah, thanks very much for the kind invitation to present here. It's my first time in the Southern Highlands campus. It's beautiful. Although I come here very often because it's a very popular spot for weddings. So I just wanted to connect with Michelle's presentation earlier. It was very good. I teach health economics at the university, and it might interest you to know that the ABS, Australian Bureau of Statistics, doesn't collect information on suicide. It collects information on what is called intentional self-harm. And for men, actually, it is among the leading causes of death in Australia. So when Michelle says, it's a huge public health concern, it actually truly is a huge public health concern for Australia. But that being said, what I'm here to talk about is my research. One aspect of that is looking at the impact of lockdowns on people's mental health. If you remember the pandemic, we've had a couple of lockdown episodes here in Australia. We're using UK data here, but a lot of the lessons learned from the UK also translates to Australia. So as Bradley mentioned, I'm an economist, but please don't take that against me. And after the talk, I don't know when the interest rates will come down. I cannot give you advice on where to invest your money in the stock market. But yeah, I'd also like to acknowledge the traditional owners of the land and pay my respects to Aboriginal and Torres Strait Islanders people who are joining us today. So, yes, this is like a quintessential image of the lockdown. First of all, you might wonder, I'm an economist, what do I have to say about mental health? Well, The issue with the pandemic is that the question for the policymakers is really, how do we balance two things, right? One is, how do we restrict the spread of SARS-CoV-2, which is the virus that causes COVID-19, versus people being able to go about their daily business, right? So the question for the policymaker here is, how do we keep people alive, but ensuring that they can still make a living, right? And economics has a lot to say about that, because economics is all about trade-offs. Resources are scarce. And so when we put money on something, that's money taken away from something else. And that balancing act is a decision that policymakers undertake on a daily basis. And because it involves trade-offs, economists have a lot to say about it. In this particular respect, we're going to be talking about the trade-offs that they're making versus the spread of the disease and keeping other things going on. But if you recall, it was a tough time. You know, I mean, if I look back, it's not that far, right? It's just 4 years ago, but it seems so far, right? I've had grown men call me on the phone, like crying, because they don't know how to teach their kids fractions, right? Like they were homeschooling and they were struggling a lot, right? You know, Alfredo, I love my kids, but my God, I want to flush them down the toilet. They don't understand the least common denominator. They can't teach them fractions. And it was tough, right? And there's no kind of like shying away from the damage to mental health. The question that we wanted to ask here is really, by how much did we have to sacrifice mental health just to stay the spread of the virus, right? Now, we use UK data. Here we use what is called the Understanding Society data set from the UK, and we measure mental health. And there's a special way we measure mental health in this data set. It's called the General Health Questionnaire Caseness Score, which, I don't know, Michelle might know something more about it than I do. It's a series of questions, 12, right? It's a 10-item question, 12-item question that asks people about whether they are able to sleep well, whether they feel they are in control of their lives, whether they are feeling anxious or depressed. So those are 12 questions, and it goes, you know, you go 0, 1, 2, 3, whether, you know, yes, I have lost control, or no, I still feel in control, and so on. Right? So you put that all together into one measure, and it's called the Caseness Score, right? And it goes from 0 to 12. And clinically, if you go to 3, right, so a pretty low number, it goes from 0 to 12. But if you go from 0 to 3, that's already clinically relevant, right? So here we have plotted that over the UK, and we've got information before the pandemic, you know, the first, you know, bluish map over there, all the way to September 2021. And if you recall, you know, news about the COVID kind of like trickling down in January, but people started kind of like taking it seriously in March, February, March, and by April in the UK, lockdown, right? So April 2020. 2 other lockdowns came into play in the UK, and that was in November 2020 and January 2021. So you can see if it's kind of like reddish or yellow, people are somewhat distressed, right? And remember, 3 is kind of like our threshold for when it becomes like clinically relevant. So the lockdowns going from pre-COVID to April 2020 really kind of shook a lot of people, right? As it did me, right? It was a tough time for many people. And you can see London is just miserable, right? Even before the pandemic, right? People living in London kind of like generally tend to be sad about life. I mean, I don't know, maybe it's the weather, but I don't know, it's not really the weather because that explains the entire UK. But I don't know, people in London are kind of like miserable, whatever. Anyway, we put that together with other data sets to look at this issue. One of them is what is called the Coronavirus Government Response Tracker that the University of Oxford put out. And it's really a measure of how stringent public policies were to contain the virus. So it's an index measure of several things, including closure of schools, closure of workplaces, whether you can take public transportation, or whether there were restrictions in public gathering, right? So the darker green, or the darker color, I don't know if people are colorblind, but the darker spots there correspond to more restrictions in public gathering, closures, and so on, right? And you can see again, April is pretty bad. January, February 2021, pretty bad, right? And this is another thing that we put together, and that is a measure of people's mobility. And this is kind of like the most interesting part of the data set, right? Because who has a cell phone? Did you know your cell phone tracks you? Shocker, right? What a shocker. Absolutely. Cell phones track you. If you have Google Maps, especially, Google Maps tracks where you go, right? And this measures how much your movements have changed using cell phone data, right? Which is much better than contact tracing. It was pretty scary, contact tracing in Australia before, because like if you were that one person, everybody knew where you went. But this is anonymized, right? It's high volume, meaning it covers basically anyone with a cell phone with some sort of Google app installed in it. And it's high velocity, right? It's almost instantaneous. It tracks people where they are. And from there, you can calculate how much your movement has changed over time, right? So if the lockdowns came in April, for example, you can see deep red, darker spots, meaning people are not moving, right? In particular, this is change in residential duration, how much time spent at home has changed over time. And people were, it's a good thing, right? They were in lockdown, and so people were staying at home to try to prevent the spread of disease, right? And the following lockdown, September, and so on, and so on, you kind of like see changes in the duration of time spent at home. Less dark now because the baseline has changed, right? Because people were spending more time at home anyway. But you put the lockdown in there and you see a huge change in the time spent at home. And that creates a whole set of issues for the family or for the units in the household, right? Because now the workspace has invaded the home space. Now the education space has invaded the home space. And that's kind of stressful for a lot of people. Now, there's a lot of graphs in the paper if you kind of look it up, but this is the kicker, right? This is the only thing you need to kind of like see. And there are a lot of numbers in there, but don't worry. The point is, it's that you see an upward sloping relationship there between two things. One is the change in duration of time spent at home. If you go from left to right, you're spending more time at home, right? And you see a measure of your mental health, which is the GHQ caseness score. And if you go from the bottom to the top, you're in worse mental health. So what this graph kind of tells you is that the more people spend time at home in a lockdown type of situation, the more stress they have in terms of their mental health. The key kind of like estimate here, I'm going to give it to you, you don't have to remember it, but a 10 percentage point increase in the change in duration of time spent at home leads to a 50% standard deviation increase in your GHQ caseness score. Whatever. I'm going to put that into context. The context is, how big is that? It's worse than getting COVID in terms of the damage to your mental health. And just about the same as becoming unemployed. Huge, right? Worse than getting the disease. Of course, the key message is not to say, get the disease and go out, right? That type of what we call non-pharmaceutical intervention of lockdowns saved a lot of lives. But we must be very honest about what it took to get us there, right? Now, the GHQ cases score is kind of like 12 questions. These are the components. And if you're interested in like, okay, which aspect actually of my mental health is being impacted by these lockdown restrictions? Well, as it turns out, almost all of them. But the key tickets here would be the first one, which is like lack of concentration. If you're trying to work and you have kids running around, that's kind of hard. And the second thing that's kind of important or has been affected adversely is the inability to enjoy day-to-day activities. I mean, for obvious reasons, right? You can't go out. Right? So those two things within the GHQ caseness are the two most impacted aspects of people's mental health. And then you can do other interesting things with the data set. I don't present everything here, but there are 3 interesting charts here that I want to show. First of all, if you're a couple, you're a little bit more resilient, right? Because I guess you have a support system, you can share the distribution of work within the household, right? But if you're single or separated, that's pretty bad for you during the lockdown, right? The second chart here kind of takes a look at age, right? For whom was the lockdown most negative? And it's really the darker spots here would be the younger kids, right? Well, I mean, not kids, they're like 20 years old, but the younger share of the population really struggled during the lockdowns. Old people, 90 years old, I mean, they weren't going out anyway. Right? It's not like, oh, now lockdown, oh, damn. No, they're fine, right? And between men and women, females had more of an adverse impact during the lockdowns, right? And it's not shown here, but if you add the fact that they have children in the household, much, much worse, right? Which kind of gives you the indication that a lot of the household production that occurred during the lockdowns really fell disproportionately on women, right? So, the men were staying at home, sure, but, it's still the women who had to do the laundry, the dishes, whatever, and they still also had to teach the kids, right? That's a plausible story that you can construct in those types of households, right? Really tough for women with children during the lockdowns. Which goes to kind of like the key issue here, and that is there are trade-offs. We need to acknowledge that there are trade-offs, right? But we need to be very honest about what it costs to get us there, right? Mental health is a serious issue, as Michelle has pointed out, in much better words than I can possibly express, right? But when policymakers try to figure out what sort of interventions I can put in place that balances these trade-offs, we must be able to at least quantify how much are we giving up to achieve a certain objective, right? Unfortunately, some of it is like really hard. In fact, all of it is kind of hard, right? What helps, of course, is that we have more data, right? We can address these questions a little bit better with, what's kind of cool for us is to use the Google data, right? That it's real time, it's fast. Surveys, annual, right? Maybe twice a month. I don't know how many times Michelle runs her surveys, maybe once, period, right? But more velocity, high volume data, we can exploit that now to inform policymakers on what the best path could be, right? Or at least what the trade-offs are, the implied trade-offs that they are making, right? Third, lockdowns are painful, right? I don't think anyone is denying this, right? But it is distributed unequally across society, right? Socioeconomic resources play a lot. Roles within the household also matter quite a bit, but we have to be very honest about what we're giving up. And for what policymakers can do in the future, right? Rapid response, online telehealth consultations, all of those things should be made available in the same way, Michelle was talking about, where do people reach out, right? Well, we need to be able to provide a lot of those resources much more quickly to the population. And in this type of research, I kind of always end with this painting of Apollo's arrow. So, two tribes, one was attacking the other, and Apollo was protecting the other tribe by shooting arrows, which represented the plague, right? But after a couple of days, 10 days actually, Apollo stopped sending the plague to the other tribe, and it ended, right? Epidemics end. I mean, we're kind of past the COVID-19 pandemic now, right? But how we get to the point where we are today really matters, right? How much and what are we willing to sacrifice to get to where we are? We're kind of really lucky in Australia because when we came out of the pandemic, hottest labor market, right? Unemployment, lowest it has been in 25 years. People could go out and get a job like that, right? But we have to be very clear. We got to that point by sacrificing quite a bit of people's mental health, right? And we have to at least be honest about that so that when future policymakers try to figure out, you know, do we lock down? How much do we lock down? For how long? Which industries? They should be able to take into account not just mental health issues, but all the other costs that are associated with lockdowns. Lots of partners and blah, blah. But, you know, anyway, I only wanted to say thank you to both the local organizers and the organizers from Wollongong for putting on a good presentation for us today. I forgot. I'm your corner.
Yeah, thank you very much for a really insightful presentation there and the information that you presented. And again, like with the previous one, I'll open it up for questions in a moment. One of the key messages that I took from that is that certainly before the lockdowns, look, policymakers have to make trade-offs, right? But before the lockdowns, they didn't necessarily know how to weight the trade-off of mental health and other issues. What would your advice be to them into the future as to how to weight it? Because it's a difficult, it's an intangible. Deaths you can weight, loss to the economy you can tangibly weight. How do you weight something intangible like that? What's your advice?
Right. So that's a really important question, and one that goes into an area that I don't like going to because it involves values, right? Economists are very good at giving you an idea of what will likely happen. Economists are probably not the same people that you want to ask about which part of society we should care more about, because that would certainly be a values type of question, right? And that's a question that is litigated and should be, I think, addressed in politics, right? Because the population elects who their leaders are, presumably to reflect their own values, and in that way translate what they think, which parts of society they should be protecting. Because each one of us here will have a very different answer to what are the optimal weights that we should assign to different groups of people. Some people will say, you know, hospital workers should probably get the highest weight because they would be the ones, you know, on the cold face and, you know, saving people's lives and so on. But what about teachers? And what about if you're comparing teachers versus firemen, or if you're comparing policemen versus firemen? Those are questions that involve a lot of introspection and looking at your own value system. And economics can say a little bit something about that, but you know, I wouldn't be the person that I would ask about who I will save in such a pandemic. But it is important. The role of an economist in that space is to at least be able to say, if you take this path, this is the group that will be vulnerable. If you take that path, this is the other group. Which path you take depends on which people you elect.
Yeah, indeed, indeed. Any questions from the audience?
I was kind of thinking it might be out of scope in terms of the couples faring the best at home. That kind of surprised me because I worked in frontline child protection at the time, and we were really worried about women in domestic violence situations and children. And there was no mechanism for reporting because we get most of our reports from education, and we weren't getting a lot of reports because of that. And then we knew that people were stuck at home with no reprieve from. So yes, being an economist might be outside of your scope, but I was just interested in that.
No, that's an excellent question, and something that is like acknowledged in the paper actually. What we have here are kind of like averages, right? So on average, yes, couples fare better, right? But once you kind of like dig into certain subgroups within the population, then you will see the kind of variation that you are maybe seeing firsthand, right? Vulnerable populations will have a different distribution of these results, right? But for the general population, which is what I just presented here, those generally hold true. But certainly, a lot of the most adverse impacts would be found not in the socioeconomically advantaged groups, because they have so many resources, right? First of all, they have savings, right? But poorer households will not have savings. They will, Michelle will be able to talk about risk factors. They would be more at risk of domestic violence type of situations. We don't dig, first of all, the data doesn't have it. The data sets don't have it, but that's something certainly that we can expect to happen, right? More vulnerable populations will have a different sort of dynamics.
Yeah.
Other questions from the floor? Online?
Yep, there's a Slido question from Cherie. He says, is there data on the continued effects on mental health of the lockdowns? Are they still impacting mental health today?
So an online question as to whether the effects are of longer duration and are still prevalent today.
Yeah. So yes, the answer to that is yes. In fact, we're learning so much more today, and that's why public policy making is hard, right? Because a lot of things are unknown. So there's a long tail for the adverse mental health impacts. We see that not just in the UK, we have Australian data as well, the household income and longitudinal data set of Australia, or study of Australia called HILDA, tracks people's mental health over time, and you can see differentiations with respect to exposure to lockdown. Like Victorians they had it really rough, right? And so the long tail of the lockdowns in Victoria, you can still see that in the data set. But again, we're still an active area of research for a lot of people, and we're still discovering new things that are coming out of the period of lockdowns. I'll give one example that's out of scope, and that is the school closures. Massive, absolutely massive adverse impacts on kids' educational outcomes, which sometimes you wonder, was it worth it to close the schools for that long? Right? So lots of very active area of research still.
My children didn't want to go back to school because I understood fractions too well. Right, Martin, another question online.
Yeah, these two might be for Michelle as well.
Michelle, could you?
So, do you think that social media contributed to the increase? I presume that means the increase in the sorts of things you were talking about. Do you want to just jump up to the mic?
So the question is whether social media contributed to increased risk factors and self-harm behaviours.
Yeah, so what we know is if we look at literature, song lyrics, movies, everything, the amount of content that is related to self-harm and suicidal behaviours is dramatically increasing over the last 10 years. And a lot of that is popular culture available to children. So they are getting exposed to some of these behaviours in ways that we probably don't even notice. So that is a factor. In terms of social media, I think our work is mostly with adolescents. We don't know that much about children, but the work with adolescents is showing that they are exposed to these behaviours at an early age, and then they can, look up and, see things that are quite graphic. But I have to say, so there are risks around social media and access to the internet, but there's also a role to play that is, the benefits. So kids can get on and access kids' helpline via phones and the internet. Like there are also other things that can be really supportive of them. So it's kind of a two-way, two-edged sword, I guess. It has benefits and it also has some risks. But I think, we also need to be mindful that it's not just exposure there. It's also, within our community and our, just what they can see and access.
And I'll ask Alfredo to respond from the mental health perspective.
So it's not my own research. It's actually one of my co-authors here from the University of Torino. But she was from UOW before she moved to Italy. And what she looks at is kind of like the relationship between social media use and problematic behavior in general, right? Including what we would call risky health behavior. So that is alcohol consumption, tobacco consumption, illicit drug consumption, and early sexual intercourse. And so it does have a relationship with those types of behavior. And of course, that eventually translates to certain mental health problems down the road. So, I mean, I don't think anyone today, like in 2024, can kind of just dismiss the role played by social media. I mean, if you step out of this room and look at teenagers, they are like on the phone, right? And so research that's coming out, well-run research, really makes me kind of like wary of how much exposure adolescents are getting on social media.
Any further questions?
Yeah, there's one more that I think Alfredo's already addressed, but it'd be perhaps good to hear from Michelle on. Where do you think the most important area for increased funding is that for support of the issues? So where should, if the funding that's available, where do you think it should be most valuable and where should it be directed?
Look, I think we have to think about the sites that children and their families are able to access readily and easily. So I think that really supporting schools at the foremost is important. So making sure that we have school counsellors or student welfare people that have the knowledge and the resources to actually really be able to intervene and support parents and carers in how they can help their child and how they can help themselves in terms of managing some of the distress that they may be experiencing about this, I think is really at the heart of it for me. And also thinking about often the next step for families can be GPs, and that's an area we haven't really looked at, and whether GPs actually have the confidence and skills to be able to respond in really effective ways that doesn't always just, then lead to a referral, which is perfectly appropriate, but there may be a long wait till that family actually gets to see someone, and we need to be able to have something more immediate, which is why I think the schools can play a really nice role if they get the support and the resourcing that they need.
Thank you. All right, so I'm going to draw it to a close there. Thank you for joining us in the room. Thank you for joining us online. And our two presenters, thank you so much for your valuable insights.